Dr. Vivek Venkatramani, Dr. Brish Bhanu Nayak. And now we have again an interesting talk, role of radical prostatectomy without a biopsy. Is it a reality or a hype? Dr. Makrand Kochikar.
Right. I think after such an exciting morning and thought-provoking sort of talks, we're just going to take one step further, treatment of prostate cancer without histopathological proof. And again, greetings from both the hospitals. And we have me here, we have Dr. Uttam, Dr. Ganesh Bakshi, I think he's left, Dr. Vivek is here, and Brishmanu. Now, why are we discussing this? Is it something like, just like a trend? Okay, we do, it's a trendy kind of thing. Or have you heard something more on progress in imaging, like what just Mihir had showed, what imaging can do? And is there any evidence actually we can do a radical prostatectomy without histopathological evidence itself? Now, many years ago, I think when we moved, through this sort of a journey of prostate cancer, actually I must congratulate you, the society, for a wonderful issue of this Indian urological clinics, uro-oncological clinics itself. And there was a wonderful sort of write-up on PSA, and it has taken on the conundrum how the PSA sort of has seen. Now, when actually the prostate cancer, we all have witnessed this last 3 decades, there was criticism, are we overdoing it? And we were called actually, the prostate snatchers. And now we have sort of, MP-MRI, we have a PSMA PET scan, and we can do a radical prostatectomy. So more and more we do it. Are we going to get blamed for it? Are we aggressive in doing this? So let us look at the evolution of cancer diagnosis. What we do is when we get a patient with the elevated PSA, we do a basic, patient had an ultrasound, we do MP-MRI next, 3 TELSA, more than 3 pyrids, we ask for a prostate biopsy, transrectal, transperitoneal, then do a PSMA PET scan, and then sort of, we plan for a treatment. So the prostate biopsy comes after the MRI and then get the PSMA PET scan. Now what people are talking now is have your MP-MRI, have a suspicion of prostate cancer, why do a biopsy, do a PSMA PET scan, is so sensitive, and then do and go a surgery. Or people are talking about having combination of these two. Are we worried about the complications of prostate biopsy, therefore we are avoiding? Mihir, your initial thoughts, those people who believe that, okay, we can use this technology, are we worried about the complications of prostate biopsy and that's why we are avoiding it?
I cannot think of another explanation why not, because, whenever you treat something without histologic confirmation, you always do worry about the downstream effects of a missed one. So that's why that could be the only explanation.
Okay, and maybe the number of biopsies done across the globe, you can reduce the number of biopsies itself. So there have been improvement in the biopsies. Initially we were doing 12 core, then we are doing targeted biopsies. We can do targeted plus standard biopsies, MR fusion biopsies. So I think you can decrease the number of sort of biopsies. That's one sort of a thought people talk about, amount of money you spend, amount of energy you spend, unnecessary biopsies. So you can sort of tailor it down. But as Mir said, maybe because of complication, that may be one thing. And I think initially when we talked about the precision study, we talked about MRI guided with standard biopsy. Here it was to trim down the number of biopsies. But the biopsies still stayed as a part and parcel of decision making in the prostate cancer. Dr. Uttam, are you convinced that the clinical, biochemical and imaging tools have such a strong evidence of malignancy that we don't need a biopsy now? Like now sort of we say renal cell carcinoma, we look at the CT, we don't need a biopsy. So are you convinced that this may be one argument?
Yeah, definitely the same concept which is there for renal cell carcinoma and pancreatic cancer, that can be actually extrapolated in prostate cancer also. But I think you have to select your cases.
Okay.
So you have only clinical data and imaging data, and you want to avoid the biopsy.
Okay.
Maybe as Mihir has told, AI might play a role, and then it will be better off to fine-tuning all these clinical as well as imaging data to remove the biopsy from this sequence.
So one way we looked at why we are avoiding biopsy, maybe because of set of complications, it can be life-threatening. Second, maybe there is emerging data suggesting that this conglomeration of clinical, biochemical and imaging is so good that we may get away with the biopsy. Now let us look at this case. Is a 65-year-old guy, PSA of 12, MP-MRI, he had a lesion in the left of the prostate, which I just showed now, PSMA PET scan like this, FDG avid lesion in the left lobe, and you look at the pathology itself, it was PT2N0, grade group 3, so I think what the images tell you, the images won't lie, it will tell you exactly sort of what the outcome is going to be. So where did it all start with? Why we are talking about this? There was actually a paper which came in European Journal of Urology, clinically significant prostate cancer without histopathological proof. Is it possible or is it a possibility in when we are talking about PSMA PET scan? And there was another paper which came from Germany without histopathological prior biopsy along with MP-MRI and PET scan. And this was a wonderful paper, almost a group of something like 25 consecutive patients, and the surgery was done without a biopsy itself. And that was something like a provoking sort of a thought and provoking literature. So let us now actually do an analysis. Let us look at the sensitivity, specificity and positive predictive value of these so-called near perfect imaging, right? Now, MP-MRI, Brushmanu, what do you think? MP-MRI, is it something really very good, or does it have a false positive, false negative in this?
MP-MRI does have, actually, it can miss your clinically significant prostate cancer in around 15% of the cases.
Okay.
Even if it is normal, it can still miss around 15% of clinically significant cancers.
Okay.
So, you cannot just, on the basis of the MP-MRI, you cannot decide whether you go ahead with doing a biopsy or not doing a biopsy. So MRI is good, but it's not 100% specific and sensitive.
Right. Okay. Vivek, what do you think about it?
So both ways, I agree. False negative as well. And so that's not a place where we are actually discussing, because false negative, anyway, we are going to go for the biopsy. The question is the false positive. What is what we see not a cancer?
Okay.
And for me, if I'm thinking as a patient, with such potentially mutilating surgeries that may be needed or radiation, side effects, I would have to be 100% sure before I go for a treatment.
So you agree the imaging MP-MRI is not near perfect as what we claim, and as we rightly seen in this slide, almost you can miss about 13 to 17% of the cases. Yes? Now,
just one more comment. So MP-MRI definitely, as the spider scoring goes up, chances of detecting this clinically significant tumor goes up. But along with that, if we add the PSA density, most probably the predictivity goes up.
Okay. So
and second thing, the problem with, I think many of us will agree to that, who is reading the MP-MRI?
Yeah.
That is the most important stuff. What I have seen in our practice, that MP-MRI says grade 5 lesions, and you do the PSMA PET scan, hardly anything is seen, and there lies a problem.
Sure. Okay. Welcome, Ganesh. We just started. We do sort of PSMA PET scan. So can you take this question, Ganesh? PSMA PET scan. I mean, how sensitive, how specific, what's positive predictive value, negative predictive value? We are talking about the imaging and its sensitivity or specificity in picking up the prostate cancer, not missing on the prostate cancer.
I think as we see the data today, it is slightly related to the PSA levels, but it has a better negative predictive value than a PPV.
Okay, fine.
So in the data which comes in.
Sure. There's a wonderful systematic review and meta-analysis of looking at the PSMA PET scan, and as an overall sensitivity and specificity of 0.097 and 0.0666, that's a specificity. And the modality has negative likelihood of ratio of 0.005, which translates into 20-fold decrease in the odds of PCA being present in the patients with negative findings. And it also suggests that it has the highest diagnostic accuracy for initial detection of the prostate cancer, and it has a potential application. This is a meta-analysis itself. And as you rightly said, Ganesh, you look at sort of, in general, you have sensitivity ranging between 90 to 100%. And if you go higher, the PSA, you go the Gleason score, I think the sensitivity is almost nearly like 100%. So it's not only just sort of, scan itself, but it also depends on the PSA and a Gleason scoring itself. And this is actually sort of another review article which will tell you about if you have PSA more than 2 nanogram, I think the sensitivity of the PSMA PET scan is nearly about 97%. And this is probably the area of patients what we are talking about. So on one side an MRI which can give an anatomical diagnosis, which will have a PSMA PET scan, PSA more than 2 is almost 97% chance, having discovered diagnosis. So can we combine these two, avoid unnecessary biopsies, pick up clinically significant prostate cancer? And this was a primary trial. This was a primary trial, a prospective multicentric study, which was actually telling you about the value of PSMA PET scan along with multiparametric MRI. And what they shown is the combination of these two with the sensitivity and specificity in the range of something like about 97% here and specificity of something 67% and negative predictive value of 91%. So this was very convincing data itself. This was a first prospective multicentric trial, a combination of PSA MRI, and it was a significant negative predictive value. So to differentiate precision trial, it was to tell you whether you do MR guided biopsies or systemic biopsies to prevent unnecessary biopsies, but the primary trial told you about the sensitivity of this. There is also a wonderful article, which is also, eye-opener, whether we really need to do this and without any histopathological proof, and it also correlate higher the pyrite score, the more chance that you will have positive PSMA PET scan and MRI. And this is another article which will telling you exactly what it looks like, combination of MP-MRI as well as a PSMA PET scan correlating with the histological proof itself and suggesting that this kind of primary clinical trial suggesting that you can still get away with a prostatic biopsy. The basis and argument for not doing a biopsy, if you have high SAV, more chance of clinically significant prostate cancer, complications of biopsy can be avoided. Patient may not be ready for a biopsy. I usually don't like this kind of argument. Patient is not ready. I think it depends on how we convince. And combination, this anatomical and function study is pretty good. Cost of biopsy, people say, is not a reason to avoid that biopsy. But anxiety, wait for radical prostatectomy, follow biopsy may be one argument. There are other studies supporting the higher sensitivity and specificity of the combined imaging. So why not do for prostate when we have for RCC, upper tract, testicular cancer, hepatic and pancreatic malignancy? However, this is not a standard of care. What if the final histopathology shows no cancer? It has medical, ethical issues. Radical prostatectomy is not a simple operation with no morbidity and mortality, cost, psychological trauma of unindicated surgery. And as it is rightly pointed out, these two tools, MRI and PSMA PET scan, it has inter-observed variability in radiological department itself. So we are assuming in that patients will opt for radical prostatectomy. But suppose patient doesn't want radical prostatectomy. He wants active surveillance, he wants focal therapy, he wants radiotherapy. I think we need a biopsy. Also, we talked about genetic testing. Baseline biopsy is essential, for understanding the biology, the behavior, and the risk assessment, and that's why the biopsy is essential. And I would suggest everybody to actually read the comment on this article in European Journal of Urology is treating images are really reasonable and these arguments are all there. So friends, we are not there as yet. As Shakespeare said, to be or not to be, or to biopsy or not to biopsy, still we do not say goodbye to the biopsy as yet. This we talked about the organ confined disease. But the point here I'm in last 2 minutes I'm going to make and show a case, because this is discussed in meetings after meetings, that what about a patient who has an established disease in terms of locally advanced metastatic disease, high PSA, rectally palpable disease, imaging disease all over, patient not willing for a biopsy. Can I go ahead and do further treatment? And I'm just wanted to share this case, which we saw about a couple of months ago. He was 72-year-old guy, 77, retention, diabetic, hypertensive. He was treated in UK and NHS. PSA 77, CT bilateral hydronephrosis, lymph nodes, bony metastasis. He had a bladder drainage, catheter was placed in. He was given LHRH analogs with bicalutamide. And the note suggested that there is a clear evidence of malignancy. In MDT, we decided not to do these things and go ahead with hormonal, ADT. 3 months persistent retention, PSA 17. He came to India and he actually opted for further treatment. He needed a TUR. 6 trials without catheterization had failed. So we did a TUR on him, and when we scoped him, the growth looked so obvious. It was almost coming through the sphincter, a lot of necrosis. Though the PSA was coming down, this was a growth. And this was the histology. This is within 3 months of ADT. And this is actually very interesting histology turned out to be, and we also ran the immunohistochemistry markers on this. It had neuroendocrine element also, apart from what we saw, and the final histology turned out to be carcinosarcoma of the prostate with neuroendocrine differentiation. This was not related to treatment effect itself. The primary histopathology had an adenocarcinoma with choriocarcinoma. So I think both the points we made it clear. We have 1 minute here to discuss, and thank you very much once again for being part of this interesting discussion. Thank you, panel.
Dr. Kochikar, so for a metastatic CA prostate also, even if the PSMA PET scan shows and clinically also very nodular, still we need a biopsy. Why? We need to have a Gleason scoring because that has got something to do with the risk stratification of the patient. So how we are going to risk stratify the patients without, that is one of the way to risk stratify. Maybe that is required. And second thing, what you have mentioned in this particular case, we don't know exact histology. So that would definitely help us or guide us for the further future treatment.
Thank you.
And also the genetic testing that's coming up, you have to do the genetic somatic mutations and other thing.
Yeah.
So you cannot completely get away with
precision therapy,
Yes,
precision medicine. Yeah.
Makrand, I am not an onco-urologist. I do general urology and reconstructive. I see, being a senior urologist, I see a couple of patients. In the last 6 months, I had at least 3 patients seen, especially of category 2, where high PSA, PSMA scan showing secondaries. And the concerned onco-urologist had started direct hormonal therapy. And in one patient, even orchidectomy was done. Now, being an expert, the insurance company, ONGC, they asked me that is it a scientific treatment or not? Why the biopsy is not done? And what to do in this case? And even if we do biopsy after the orchidectomy, will there be any change in the gradation or anything? I really don't know. But in one case, one patient has gone into the consumer court on that basis. So I just need a guideline or expert comment.
Basically, I think it's a counseling. Whenever actually we do treat any cancer patients, I think in our clinic, and I'm sure most of us, we follow that. We have counseling 1, counseling 2, counseling 3. First initial discussion, then the staging, and then further plan of treatment and a long-term treatment. Everybody goes through the MDT. So it has to be on paper what strategy you have been sort of adopting and giving to the patients. It has to be documentation. Even for your government scheme, there has to be an MDT on the piece of paper. Now, if you have justified in saying that there is such a clear-cut evidence and why do you do not a biopsy, probably you will be saved in the consumer court. But you assume that there is a prostate cancer, not justify on a piece of paper, I don't think you will stand any chance in the court of law. I personally feel I think the biopsy should be done, before you embark on any treatment for that. Second thing, now doing a biopsy, I think if you have a residual disease, obviously, you will find a disease. An expert pathologist would be able to also tell you if there are post-hormonal changes. I mean, there are pathologists who will tell you the biopsy has been done. Like, when you have elevated PSA after sort of, hormonal therapy, you do a transrectal biopsy, you do CTD, circulating tumor DNA cells. These patients, pathologists would be able to tell you there's a treatment, post-treatment effect, and possibly there was a disease to start with. So ultimately, I think as of today, we are safe to do a biopsy. We still can't get away without a biopsy.
Thank you, sir. Thank you.
Thank you.
Thank you, panelists.